Hello, everybody. Welcome to this month's Winona Perspective Patient Q&A. I'm Angela. I work at Winona, and I'm here with two of our amazing Winona physicians who are going to be answering your questions this hour. I'm going to let them introduce themselves, and then we will get started with your questions. So take it away, either of you, whoever wants to go first.
I'll go first. We'll say ladies first. I'm Dr. Kathleen Brown. I'm one of the Winona doctors. I take care of patients in Pennsylvania and in Florida. I was in the Army for a while, and I'm in the Philadelphia area myself, here to dedicate my career to helping women. Most of the time, I work as an OB hospitalist, and I do Winona as a second job, really helping a lot of patients getting through this menopausal transition. So here to answer your questions, and I'll give it to Dr. Green to introduce himself and then tell you a little bit more about the process and what Winona is about.
So hi, my name is Mike Green. I'm also an OBGYN and also work as an OB hospitalist, among other things. I actually have 4 different hats, but a little busier than I should be. I've finished residency in '99, so I've been doing this a long time, but basically my whole career has been doing women's health, and it's something I'm passionate about. I also happen to be the chief medical officer of Winona, and I basically designed the whole onboarding and all that. So what started off as sort of a little side project has pretty much taken over my life, and now I'm just part-time with the OB hospitalist and pretty much do this for the rest of my life. My wife will attest to that. It's fun, and this has been an absolute joy, and it's a real pleasure to be able to take care of you guys. So I just wanted to talk briefly about the process, what you can expect. By the way, this gets really uncomfortable and boring if you don't put questions in. We start staring at each other and like trying to think of something to say. So please type your questions in. That's really what this is for. So I'm going to stall a little bit as you put your questions in. What can you expect when you onboard as a patient to Winona? And when I built this, I really basically asked myself, well, if this was a patient in my office, what would I do? And so generally you interview the patient, find out what's going on, their symptoms, their medical history, that kind of thing. And then you come up with a plan and suggest a plan, see if the patient thinks that's a good plan. If necessary, some back and forth. We call that shared decision making. Then you provide the prescriptions with instructions, and the patient goes home and uses the prescriptions. And then I generally see patients back when I start a new medicine in 3 months to see how things are going, make sure there's no side effects, make sure it's working. If everything's great, then we do this, refill it for a year, and we see each other every year to touch bases. If it's not great, we make some adjustments till we get it right. And so that's basically what we do with Winona. So you're going to start off with what's called an online adaptive interview, which is basically you'll be answering questions. Everyone gets a different experience because questions change depending on how you answer them. And it's sort of probing like we would do in the office to get all the information. And then I have an algorithm I designed that gives you a suggestion of what we think would be right for you. You say, yeah, that looks great. That goes to the doctor. The doctor reviews everything and makes sure, yes, this is safe. I didn't mess up my algorithm and everything's okay. And if that's the case, then they prescribe the medicine and give you instructions, just like we do in the office. Sometimes you might have questions, or the doctor might have questions, and so those can be posed, and there's some back and forth until we get it right. And so sometimes it's just, yeah, that looks great. Yep, that looks great. And you get your prescription. Sometimes there's some back and forth with questions to clarify things. And unfortunately, every now and then there's somebody that isn't a good candidate for these medications. And so number 1, 2, 3, and 4 is safety, 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 safety. My primary job is to protect your health. If I relieve your hot flashes, but I kill you, I haven't done you any good. So occasionally there'll be things that just aren't safe to use these medicines for. And so, we won't prescribe them. And occasionally people get angry. I feel bad for them because they're frustrated. I understand that. But really, if we turn you down, the only reason we would do that is because we think there's a real health concern and we don't want to hurt you. So that's the most important thing, is to make sure that this is done safely. So that's sort of the process to expect. We have a nice messaging platform, and so you have access to us anytime you want. So if a question pops up or a problem, you can message in. We're pretty responsive. Honestly, I get back to my Winona patients faster than I get back to my office patients. So you have really good access to your doctor if there's an issue or a question. We're happy to field those. We also have a very robust patient services department. These people are just absolutely fantastic. So if there's problems with billing or shipping or that kind of thing, we've got people that can help you with that as well. And so that's sort of the big picture of what to expect as you become a patient with Winona. So it looks like we got a bunch of questions, so I can stop yakking and we can answer some of your questions.
It's good. I'm so happy to see so many people here. Okay, first question. It's the initial E, so I'm not sure the first name, but they're asking, does the prescription end when you turn 60?
Well, the truth is that we know that it's safer for women to start HRT before the age of 60. But if you're starting it before the age of 60, it's not necessarily that when you hit that 60th birthday that we abruptly shut you off and turn it off right away. So that's a decision that we make together with you when it's time to decide to try to go off the medications. But it's not like as soon as you hit 60, then you're cut off. But it's important that we start HRT before you turn 60, just because there's some increased risk for heart disease if we start it too late in life.
Okay, next question. Jayasri, I hope I'm saying that right, would like to know, what is the difference between natural bioidentical topical cream versus the BioT pellet regarding side effects? They've been taking the pellet for 3 years from January 2020, and they have, it says man pattern hair loss because of high testosterone. How do I know how much testosterone I need for my body?
So I'll field that one.
Okay.
I'll be honest with you. I don't know how they talk people into BioT. It's a painful, invasive process. And the concept doesn't really make a lot of sense to me. So it's very testosterone heavy. And the idea is that the testosterone eventually breaks down into estrogen. It's kind of like trickle down economics, but with hormones. And so I think women often get exposed to a lot more testosterone than they need. And it tends to cause a lot of testosterone side effects like male pattern hair loss and among other things. If you're doing BioT, it's actually really important to follow testosterone levels. It's sort of the one hormone level that needs to be followed in some situations. We don't provide testosterone in Winona for several reasons. The most practical being is that we're not allowed to legally with this type of telehealth. But we do provide something called DHEA, and in the doses that we prescribe, it's enough to bring your testosterone to normal female levels, but without overshooting into male levels. Testosterone is a performance-enhancing drug, and we see the bodybuilders and the athletes, using huge amounts of testosterone, and there's a lot of side effects that can be associated with that. And so, to me, a testosterone-heavy treatment for a woman doesn't make a lot of physiologic sense. Plus, there's risks with the pellets because it's an invasive procedure. Furthermore, if you get one and you don't like it, you're stuck with it for 4 or 5 months while it wears off. Whereas if you're using the cream and you don't like it, you just stop using it and it's out of your system in a day or two. So it's a lot safer way to do it. The creams really are estrogen and progesterone based, which is the primary hormones that women need. They do need a little bit of testosterone. We provide that with DHEA, which is a much safer way of doing it with a lot less side effects. So that's kind of the big picture spiel about the BioT versus the cream. Helps.
Okay. Cheryl would like to know, for women that have had a hysterectomy but still have their ovaries, what help for menopause can they use?
Well, so when you've had a hysterectomy, that means you no longer need the progesterone component really of the HRT. So, typically when we do the compounded cream, it has estrogen and progesterone. The progesterone is really to counterbalance the effects of the estrogen on the uterine lining. So when you've had a hysterectomy, you don't need that aspect. So you could do estrogen replacement either in cream form, in pill form, or in patch form. Because even though you still have your ovaries, and depending on your age, your ovaries are going to continue to produce some estrogen. As we age, that estrogen production declines. And so you're going to benefit from estrogen replacement as you go through this perimenopausal transition. So that's the short answer for that one.
Okay. Soraya says, can a patient who's had a previous blood clot, was tested no clotting factors, and I guess was due to a long surgery under general anesthesia, she was told that because she was obese, she could not have estrogen?
Well, so having a blood clot, and when we talk about blood clots, there's a lot of different ways to talk about that. Some patients will talk about blood clots, meaning passing blood clots with their menstrual cycle and heavy menstrual bleeding. But with this, I think you're talking about blood clots in the leg or the lung, what we call a DVT, or deep vein thrombosis, or even a pulmonary embolus. And when you have a condition like that, you're really no longer a low risk patient. So this is something that many physicians would feel pretty reticent to prescribe hormones, just because they can make your blood what we call more clottable or hypercoagulable. And so you would be someone that I would recommend see a physician in person, not really a candidate to do telemedicine for HRT, unfortunately. So, if this is something you want to explore, I would recommend making an appointment in person to talk to somebody about it.
Okay, Cheryl has another question. She's asking, I'm assuming this means, will HRT help for all the midsection weight gain due to menopause?
Yeah, so if your weight gain is related to a lot of the hormone changes, which it's very, very common for us to start to notice this accumulation of weight in our midsection. We call it the menobelly, or some people will call it, meno shelf. We start to notice that because of the change in our hormonal environment, we can start to accumulate weight in that section of our body. And so if that's your main concern, then balancing the hormones with hormone therapy will help you with that weight loss. Once we kind of get your levels in an optimal place and you're doing well, you'll start to see that weight reduce.
Okay. All right. Our next question is, and this is a good question. What is the difference between Winona and what my gynecologist can prescribe?
I'll take that.
Yeah.
That's okay.
Sure.
Okay, so technically, your gynecologist can prescribe any hormone replacement therapy. However, most gynecologists don't have access to a compounding pharmacy and honestly don't know how to use compounded medication. So the creams that we use, we have our own compounding pharmacy with our own pharmacists that are just absolutely fantastic. And I'll be honest with you, before Winona, I didn't know how to do compounding medication. So it was something I had to get educated on and learn because it's not something that most people do in their office. I see patients, I live in a small town, and just to be part of the community, I see patients a couple half days a month in our little rural health clinic. We don't have a compounding pharmacy here. So patients that see me in the office do not get creams. I don't have the ability to prescribe them. So that's one difference. But the main difference really, honestly, is more convenience, number one. And number two, you're dealing with somebody at Winona that does HRT. I mean, this is pretty much like all we do on this platform anyway. And I can tell you in private practice, I mean, I did some HRT, but you don't do that much of it. Most of what you do as an OBGYN is take care of pregnant ladies. We do a lot of birth control, we do surgery, and we do a little bit of HRT. And so with Winona, you've got people that are doing HRT all day long. And so we've gotten really good at it. So you get some expertise that you wouldn't necessarily have. But the big thing is convenience. I mean, honestly, let's say that you decide that you want to find out about HRT, and so you make an appointment with your doctor. And depending on how busy your doctor is, that can be a long time. Last time my wife made a Pap smear appointment, it was a 6-month waiting list. So you wait however long that is, and your day finally comes. And so you go to the office and you sit in the waiting room, hopefully not too long, but sometimes for an hour or so, or the poor doc has a delivery and runs out of the office. He or she runs out of the office to catch a baby, and either they reschedule or you sit there all day. And you finally come back, they put you back in the little room, and then you wait in the little room for another some amount of time. And then the doctor comes in and you discuss the issue, and then the doctor may or may not prescribe HRT. If they do, you get your prescription. These days, it's probably going to be sent electronically to the pharmacy, but you still have to go to the pharmacy, wait in line at the pharmacy, pick up your prescription. And then if you're like me, grab an ice cream cone on the way out, which probably isn't good for that midsection weight. But that's a lot of time spent with some unknowns. So with Winona, you sit in front of your computer or you sit on your phone and you do the online adaptive interview and some interaction over messaging, and boom, the prescriptions get delivered to your house. So except for walking to your mailbox, you never really have to even get out. So it's a much more convenient way of doing it, and you have access to really some specialists, some experts, and medications that you don't necessarily have access to with your GYN.
Not to mention the bonus of not having the Rite Aid pharmacist yell out over the loudspeaker, Angela, your vaginal atrophy is ready. You're like, oh, my neighbors are in the store. So it's always a bonus to just have Winona come to your house and you just open your package. No one knows your business. Anyway, sorry for the share, but relevant. Alicia says she has is an ovarian cancer survivor, and she wants to know if HRT is right for her. She's 53 and 4 months without a period and is losing her memory and her hair.
So unfortunately, being a cancer survivor also puts you in that very high risk category. So when you have a higher risk medical condition, it's best not to do HRT through telemedicine like this. It's better to see a doctor in person so they can examine you, follow you more closely. So unfortunately, you wouldn't be a great candidate for Winona with that history. But I'm happy to hear that you're a survivor. That's great news.
Christina has a question. She says, will this work? I'm assuming that's HRT. If you are on Sprintec oral birth control.
Yeah, so birth control hormones are a little different than HRT hormones. So, the birth control are synthetic female hormones that we're using to suppress your ovulation, to prevent pregnancy and prevent that egg from getting fertilized. And so HRT is a little different in that we're just trying to replace your body's own natural inherent hormones that are being lost. And so you can still be on birth control and have perimenopause symptoms and start experiencing hot flashes, vaginal dryness. And so it is safe to take them together. Generally, we recommend if you're on birth control that once you hit age 50, you could probably stop that birth control at that point. But it is safe to take them together in those years leading up to that, that time.
Allison says she does not have a ton of symptoms. She's in perimenopause, not full menopause, but her joints and knees have gotten bad and they're slow to heal. And she gets really bloaty and feels full mid-month. And she has a history of fibroids. Can she expect HRT to help with these? And she really appreciates our service.
Well, joint pain is something that is a very common symptom of menopause, but it's also a very common symptom for us as we age. So it's one of those things that it's hard to really tell, what is the source of that. If you're also experiencing other symptoms of menopause, which if you were to search for a list of comprehensive symptoms of menopause, you can see some infographics that might be out there on the internet. Sometimes it's 30 things that are listed, sometimes 40, sometimes more. But if you're having other symptoms like night sweats, hot flashes, you're starting to experience insomnia, starting to experience brain fog, which my perfect way to explain brain fog is you're doing a project, you have to go in the other room to get something. And when you get in the other room, you forget why you even went in there.
Yeah.
That happens so often, but it's those sorts of things happen more often at this time. But if you're having those other symptoms that kind of go along with those menopause symptoms, then if the joint pain is then starting kind of new at that same time, it might be related to the menopause changes as well. So in that sense, HRT should help with that. Estrogen is beneficial to so many tissues of our body. And so it's one of those things that it really can benefit a lot of the symptoms that you might be experiencing. But if you had joint pain before your menopause symptoms started, it might not be just related to the hormone changes. It could be arthritis, it could be age-related changes, things like that. But generally HRT will help some joint pain.
Let me cover the second part of that question, which was the fibroids, I believe. Didn't you ask fibroids? So, fibroids are incredibly common. If you took 100 women off the street with no symptoms and did ultrasounds, at least 25 of those 100, some would say 50, have some fibroids. So fibroids are very common. For most women, they don't cause problems. For some women, they cause really significant problems. But for most women, they're just sort of there. And generally speaking, for most people, fibroids does not preclude the use of HRT. So HRT is generally fine to use in women that have fibroids. Now, if you have fibroids that are causing you problems, then it may not be sort of the best thing. But if you sort of had fibroids in the past, and maybe they caused problems then, and now things have quieted down and they're just sort of sitting there, then HRT would be safe to use with the fibroids.
We have another good question. Melissa says, what if we think we're in perimenopause, but it hasn't been confirmed and symptoms vary?
Well, so there's really no way to confirm that you're in perimenopause. Many of you may have gone to either your family doctor or your gynecologist and started to talk about symptoms and started to say you might be starting to experience this. And often, a lot of doctors out there will often offer to run a hormone panel to check and see if you're menopausal. And really, there's no labs that'll tell us that you're perimenopausal. The only way we can confirm with labs is to tell you that, yes, indeed, you have gone through menopause when it's already completed. But the labs really aren't that helpful. So if you're experiencing symptoms that are distressing to you, if you're starting to notice changes on a day-to-day basis that are affecting you that kind of fit into this perimenopausal symptom profile, like the hot flashes, you might notice a decrease in vaginal lubrication or vaginal dryness. You might notice some skin and hair changes, the brain fog. You might be noticing you're getting up several times a night, feeling hot, covers off, covers back on, having to change the temperature in your bedroom, and your partner might not be very happy with that. Those symptoms are very, common for a lot of women going through this transition. And so if you're in perimenopause and you're starting to have symptoms and they're bothersome, you could still benefit from HRT. Waiting until you've completed the menopause transition, sometimes at that point it's a little too late. Never too late to really start hormones if you're going through it, but they can be more beneficial. The HRT can be more helpful for you if we start it when your symptoms start to become bothersome. Oh, the next patient said, yes, don't kill us.
Yeah.
I love that, Allison. That's cute.
Someone gave me a book when I started residency that was titled "Try to Kill as Few Patients as Possible." It was a joke, but it was funny. Tongue in cheek, obviously.
Cindy wants to know, should she wait a certain period of time after having had a full hysterectomy last December to start HRT? She feels horrible currently.
Yeah, the answer is no. There's no point feeling horrible. Maybe a week or two until you're ambulatory. But if you're feeling miserable, you've already waited longer than you should. And life's too short to be feeling miserable. And fortunately, there's medication that can help. It's safe and works and makes you feel better and improves your quality of life. Why not? And so, it would be very safe to do that. There isn't no waiting time after hysterectomy, and it should really change your quality of life.
Okay, we have another good question. I'm taking notes, so if you all see me writing, I'm not listening. I'm actually writing down important questions for social media. Just so people know, I always feel bad that I'm looking distracted.
You're planning your next Instagram video.
Huh? I'm planning my vacation while you guys are talking. So Marnie would like to know, how does Winona differ from the estradiol and progesterone her doctor has prescribed?
So I think we talked about that a little earlier, in that your physicians typically are restricted to the medications that are out there that are FDA approved that they can send to your pharmacy, whereas we have the ability to do the compounded cream that's unique for you. And that's the main difference. The medications are similar, but it's, making something that's unique to you and that's going to be delivered to your home without the inconvenience of having to go to the doctor's office and go to the pharmacy. That's the main difference. And Dr. Green covered that earlier. We talked about that a little bit before.
Okay, I just responded to Christina in the chat. She was asking if our webinar is for perimenopause women or menopausal women, and I just said it's for both, all. And
anybody that has a vested interest in the topic could attend, right? I mean, it's,
absolutely.
Yeah.
If you're gathering information for a relative who's in either of these spaces, etc., friend, whatever, doesn't matter.
It's funny. I get patients that are worried that, I'm through menopause, I guess I can't use this. And then I get other patients, I'm not in menopause yet, I guess I can't use this. So, and it works both ways. So you're a candidate on either side of the quote menopause. So anytime during that transition period, before, during, and after.
I'm sorry, I'm trying to find my spot back in our chat because there's so many questions. Okay, so Claudia says she read that bioidentical progesterone doesn't absorb quickly or easily, leading to suboptimal levels that put women with a uterus at risk for endometrial cancer when they're also receiving estrogen. Why is this not disclosed upfront?
So I'll take that one. That's not disclosed because it's not true. So it's one of these half-truths. The problem is that not all compounded medications are created equally. And there have been issues with this. So you can go on Amazon and you can order a progesterone cream. And I can tell you, without a prescription, and I can tell you that progesterone cream has a teensy amount of progesterone, enough so they can put it on the label, but not so much that you need a prescription. And those progesterone creams that you can buy over the counter or from somebody that's not licensed will not protect your endometrium. And yes, put you at risk for endometrial cancer. And that's a big problem because for a lot of patients, they don't know the difference. Somebody's giving them a progesterone cream. They think they're protected. The progesterone cream is baloney. It's got just a token amount of progesterone in it and it's not protecting them. And so, yes, there have been problems. The progesterone, the creams that we use at Winona are designed to have enough progesterone in them to protect the endometrium so that you're not at risk of uterine cancer. So that's why it's not disclosed, because the creams that we use, it's not true. We have a minimum amount of progesterone that we put in our creams, and that can change with the amount of estrogen you're having, but we make sure that you always have enough progesterone to protect the uterine lining if you still have a uterus. Now there were some studies that showed that the progesterone in the cream gives you a little bit lower drug level or blood level than progesterone's, taken orally. But there are other studies that actually show the tissue levels where it really counts. So what's the progesterone doing at the tissue where it's supposed to be working are totally adequate with appropriate doses of progesterone cream. So unfortunately, people use this. There are certain people on social media that really, for some reason, use this as a weapon and talk about us now and then that we're supposedly doing something horrible by prescribing these dangerous progesterone creams, and it's just absolutely not true. We would never do that. We've had literally tens of thousands of patients, and we're not seeing patients have this problem. This is a very safe way to do it. On the other hand, if it's something that you're nervous about, we can certainly provide an oral progesterone along with an estrogen cream, because honestly, even though I know it works, I don't want you staying up at night scared to death that your uterus is getting poisoned by the cream you're taking. So if it's something that worries you, I'm very happy to split it out and give you an estrogen cream and a progesterone pill, because the last thing I want to do is cause you anxiety. But our physician sort of first rule is do no harm. As somebody joked, please don't kill us. That's really our first rule, and we wouldn't be prescribing these things if they weren't safe. So it's not disclosed because it's not true. But again, if you feel uncomfortable, we're very happy to do it another way. I want you to feel comfortable with the treatment you're taking. It doesn't matter that I feel comfortable, it matters that you feel comfortable. And so that's a really important distinction.
Awesome. That's such a great answer. Thank you, Dr. Green, for unpacking that. Christy, I'm assuming, is asking, because the first part feels missing, how often does this cause, I assume this means HRT, how often does this cause a period to return if you're slowly transitioning to not having one? She's currently 10 days late.
Well, if you're still having regular cycles, you may continue to have cycles, or even if they're irregular. We can't say you've completed menopause until you've gone a full 12 months without actually having a period. But if you've stopped having periods and it's been a year or two or more that you've not had a cycle, it's not going to kickstart your periods to start happening regularly again. It can be common to have maybe a little bit of spotting here and there as your body's getting adjusted to the hormones when you're first starting them, or if you're changing dosages, but it's not going to cause a full-blown period to just restart. It's not like you're going to bring it back to life if it's stopped for a while.
That's the good news. Pam says she is on Winona's transdermal combo cream now for 2 months, and she feels super emotional and bloated, and wants to know at what point can she expect things to level out and to feel better.
I mean, generally bloating is a common symptom that a lot of my patients experience in the early part of starting the medication. But usually within that first, after that first month, it gets better. So if you're still experiencing a lot of those symptoms, then it might be worthwhile to talk to your doctor about maybe adjusting dosage. And we'll want to look at your other symptoms too, like the other symptoms that brought you to Winona. We want to know if we're going to adjust dosage, are you getting adequate control of your hot flashes and the other things that brought you to us? Because we want to make sure that by improving the bloating, that we're not going to then make your therapy therapeutic, and you're going to start having a rebound of those symptoms back again. But generally by the 2-month period, a little bit after, you should start noticing that some of those side effects should subside. So if they haven't, it might be time to tweak the dose.
Okay. I just answered the next question in the chat, which was about insurance and if we were going to expand to take this person's insurance. And I just explained that you can use your FSA or HSA card if you have one, or you're also welcome to ask your insurance if they'll reimburse you for our prescriptions, but it's really case-by-case basis with your insurance provider. I mean, if you have either of you anything else to add to that, feel free.
Yeah, I mean, I'll just say straight out that we have no plans to take insurance at this point. I mean, that obviously can change. We're, we're a fairly new startup. We've been around for a little over 2 years. 2 years last April. We've grown tremendously. It's pretty exciting. And who knows where this is going to take us. And, it's possible that we could become that unicorn and become, the main national player and go public and all that stuff. And then maybe that would be a time to consider insurance. So I would never say never. It could happen, but honestly, that's not something that we're really talking about doing. But we do take HSA, FSA cards, and we do have patients that are successful in getting reimbursement from their insurance. We provide the receipts. We won't fill out your prescription. I was talking to a patient today about this. So when we first started out, we were trying to fill out insurance forms for people, and we found out that what these insurance companies do is they just keep asking for more and more stuff, and no matter what you give them, they're never satisfied, and it's just a way to put it off so that they don't have to pay for it. So we realized this is just a waste of everybody's time, and it's just not worth. It's not worth the time because we never won. So we have forms that we give you that any reasonable insurance should accept, and if they're not going to accept those forms, they're not going to accept anything we give them, and that's what we found. So we do have forms that you can download that have all this stuff, all the codes and those things that the insurance should need. And for some people it works fine, but unfortunately, insurance companies are in the business of trying not to cover your healthcare, and they're pretty good at that, unfortunately. I don't know if you remember in now I just forgot the name. The superhero movie, the cartoon with the Elastigirl and anyway.
Oh, The Incredibles.
The Incredibles. If you remember,
yeah, he was like an insurance agent. He got in trouble for paying the claims.
Right, exactly. And so, his boss was all mad at him. We're not in business to pay claims.
Right.
And unfortunately, there's a lot of truth there. I live in Lake Arrowhead. We had a historic storm this winter, and we had some damage. And apparently, there's a little fine print that says our insurance doesn't cover snow damage, so they didn't.
Oh, wow.
But that's how insurance companies make money. So that's probably not in the cards anytime soon, unfortunately. I understand from the patient side, and I kind of wish it wasn't the way it was. And maybe our insurance system in the United States is a mess, but maybe that will change. But for right now, it's not something that we just don't have the resources to do that for you, unfortunately.
Okay. Thank you. Tiffany would like to know, are there any studies about long-term effects for HRT in perimenopause? She's in perimenopause and really hoping for relief, but worried about having to do something like this for 15 years.
I mean, there's definitely studies out there showing the benefits of estrogen replacement therapy. for health benefits in women especially. So, in preventing Alzheimer's and preventing osteoporosis. And also estrogen can be cardioprotective as well. So there's a lot of good benefits that estrogen can give you. And, as far as being worried about taking it for a long period of time, it's really an individual decision that you make with your physician about how long you want to stay on the medication. And it's really about, for most patients, the lowest dose they need for the shortest duration that they need to help them through this process when they're having these troublesome symptoms. We don't want to keep you on a medication indefinitely if you're not going to need it. And a lot of times when it's time, I've had patients come and say, I want to try to get off of this. And so we start to stop the medication. And if they don't have a resurgence of symptoms and they do well off of it, then it's time to stop, and we have that decision-making conversation with you. It's not something that like once you start, you can't stop and you're stuck and you're on this until you die. It's not the way it is. Really, you're taking care of you, as your physician. It's a partnership that we have with you. And so these are discussions that we have back and forth with each patient.
Okay. We have a question. Do symptoms return after going off medications?
Oh, I kind of just started to talk about that a little bit. So if you suddenly abruptly stop medications, and you can get a rebound of symptoms. And so that's something that you may experience, but not every patient has that happen when it's time to kind of finish their treatment. After they've been on the medication, maybe 3 to 5 years or something, they may not necessarily have the symptoms come back full force. And every patient is unique. So, it's one of those things it's individualized that patients will experience that.
I like to say, once you've been on it for a few years, try going off, but don't do it like right before your kid's wedding or something. You're going to have kind of a low stress time so that if the symptoms come back, because it may take a couple months to get them back under control. So, be smart about the timing, but absolutely there's no point being on a medicine you don't need. And so it's worth kind of experimenting every now and then. I would give it, like 3 to 5 years initially, and then kind of see how you feel. But I do have patients quite a bit that go off it and then they message me back after a few months. Help, please restart me. I kind of feel bad for them, but at least we've got a way to make them feel better after.
Right.
Do you titrate? Like if you like say that's me and I call you and I go, oh my God, Dr. Green, Dr. Cat, you guys, I'm having this problem. Do you then just put you back on the dose and you go down slowly, or what do you guys end up doing?
Every patient's a little different. I've had patients that just want to stop abruptly. But if you want to have like the most seamless transition, we can kind of try titrating down and kind of weaning you down, gradually so that your body has has chance to kind of acclimate to each stage before you finally stop the meds.
Mm-hmm.
Yeah, it's not one of these medications that's dangerous to stop abruptly. So for instance, if you're on a beta blocker and you stop it abruptly, you could have a hypertensive emergency. So please don't do that. And certain SSRIs are that way too. But HRT, if you stop it abruptly, it's not a health risk, but it may be easier to wean it. There's different ways to do it. And they also, we should be on any medicine on the lowest effective dose. So sometimes there can be, hey, this has been working really well for a while. Maybe we should try and cut the dose down and see if you feel just as good on a lower dose. Is another reasonable way to do it.
Jamie would like to know, is it okay to take DIM with your estrogen cream?
So my general rule of thumb is no. Just in my own research about DIM, and those who haven't heard of it, it's a natural supplement that you can buy at some of the vitamin stores or online, that's supposed to enhance your estrogen metabolism and make your female hormones more readily available. Because we don't really have studies out there based on this supplement and what reactions it has in the body, I really just don't want to take the chance that it could interfere with the benefits that you could get from your estrogen cream. So I generally tell patients to stop the DIM when they start our medications. I don't know what you do, Dr. Green, what your rule of thumb is.
So yeah, people aren't going to like to hear this, but I think it's a placebo. So I don't think it really does anything. So basically I tell people, look, it's probably not going to help you. It's probably not necessary. So why spend the money on it? But if you feel attached to it and you want to continue it, that's okay. But why I'm a cheapskate. I don't like spending money on stuff I don't really need. So why spend money on something that may not be helping you? So, and that's for, a lot of these supplements, or some of them help a little bit. Estrogen is a good example. I think it helps a little bit. But really, once you're on HRT, you kind of don't need that little bit anymore, because you're getting
Right.
And so you can stop it. Usually I say, wait, at least if you think it's helping you, wait a few weeks for the Winona medication to really kick in, and then go ahead and stop it at that point. But, it'll save you a little bit of money. And some of these supplements will save you a lot of bit of money. Some of them are quite expensive.
Mm-hmm.
Yeah, they really are. Okay, this is a funny question, but a good one. Christy says, if you're already getting those pesky chin hairs, will these meds make that worse?
In my opinion, no. I think it makes it better. So generally, those pesky little chin hairs can start to pop up when your hormones are going awry. And typically when we replace estrogen, it improves that. And so you start noticing hairs that are unwanted and thicker in areas that you don't really want them or have had them before, generally start to get, thinner, and they'll to kind of not be as prevalent as they were before when you start the estrogen. And also your skin and your hair quality in general gets better when you supplement with estrogen. So, typically those chin hairs come from some of the male hormones that are starting to creep their way in, and your estrogen levels are getting lower, so it will get better.
All right. Gabriella is saying she's never had breast cancer, but sees a breast doctor twice a year for imaging due to high incidence of breast cancer in her family. Appears to be environmental. She's tested negative for gene testing, and she's not on birth control. Would she need clearance from her provider for treatment?
No, it sounds like you would be a good candidate for treatment, especially if you've not personally had a history of cancer.
Awesome. Okay, Rowan has a question. Is there an estrogen cream for the vaginal area to help with urethra irritation?
Yes, we do carry an estrogen vaginal cream as well. So, if your symptoms are mainly vulvar and vaginal, if you're noticing a lot of dryness, as far as urethral irritation, the urethra is the opening that the urine exits the body from, the bladder. If you notice symptoms of irritation or burning when the urine exits your body, sometimes replenishing the tissue in that area with estrogen can help reduce those symptoms. So a topical vaginal estrogen cream would be really helpful for that.
The estrogen cream works great for vaginal symptoms. Really works better than anything else. Doesn't work so well for the other symptoms. So a lot of people end up being on both, which is totally safe to do. So we have a lot of patients that are on one of our compounded HRT creams, or a pill or a patch, and also using the estrogen vaginal cream, because they really do different things. But it can be a really nice addition if you're having those symptoms.
Okay, Michelle, actually Rowan still has a part two. Will this have any effect on an antidepressant med? Also, probably more than halfway through perimenopause, will there be any downsides for starting this late?
No, the meds won't interact with your antidepressant medications. I have noticed in some of my patients that needed to start antidepressant medications that once they get their hormones balanced, they might notice they don't need as high of a dose, that they're able to dial back on their antidepressants a little bit in some situations, but they're perfectly safe to take together. And there's no downsides to starting HRT at all when you're going through perimenopause, no matter where you are in that transition. Like we mentioned earlier, once you're having symptoms that are bothersome and they're really affecting your day-to-day life, it's perfectly a good time to start HRT at that point.
If you go online and you research DHEA and antidepressants, particularly SSRIs, you're going to see a warning that it can cause a serotonin storm or problem. But that's the problem with DHEA, is that it's a performance-enhancing drug. So I'm a bit of a gym rat. I don't use performance-enhancing drugs because I do it for my health. But I've got some big friends that do, and DHEA is one of the things that they use, and they use these massive quantities of DHEA. In those massive quantities, it can interact with an antidepressant, and so you may see those warnings online, and it's kind of scary. In the 25 to 50 milligram dose that we use, it's not enough to interact with your antidepressant or SSRI, so it would be safe to use. But just to give you a warning that you may, unfortunately, like, fortunately, unfortunately, the internet is great because there's so much information, but unfortunately, sometimes that information is not relevant, but it looks relevant and it's scary. So I hate, I want to try and be proactive so you don't read something like, oh my gosh, this is a problem, and then you're in a panic, because that's no fun. So if you see that, that's what it's talking about.
Okay. Michelle would like to know if there's any testing done to show that progesterone absorbs well enough in cream form to protect the uterus. She says she's seen so many people say it does not absorb enough and oral progesterone is the only way to get enough.
So we covered that. So you're probably late to the party, which is fine. So I'm going to give the Reader's Digest version. But basically, the answer is that progesterone creams that have an adequate amount of progesterone in them do protect the uterus. And our creams are all designed to be protective, and they work. And there are studies that show that progesterone creams in an appropriate dose do protect the uterine lining. And I know this is pretty prevalent out there on the internet. Beware of these progesterone creams, but really it's the progesterone creams that don't have enough progesterone in them that cause problems. So you can buy a progesterone cream on Amazon that has just a teensy amount of progesterone, and that is not going to protect you. And unfortunately, people think they're getting protected because it says progesterone on the tube, and it's not working. The creams that we use are prescription strength. They're designed specifically to have enough progesterone to protect your uterine lining, and so they are safe to use for HRT.
Okay. Sorry, I'm scrolling back. I lost my spot. It answered somebody's question. The next question was, are medications plant-based? And I was saying, yes, they are. Correct me if I'm wrong, Dr. Green or Dr. Cat, the DHEA capsule exterior is not, right?
Correct.
Okay.
It has some gelatin in the capsule. So yeah, that's the only thing that's not.
But the hormones themselves are all plant-based. And actually, the progesterone pill also has a gelatin cap. The progesterone capsule, the oral progesterone, has a gelatin capsule as well. So for some reason, these capsules all have gelatin, which are bovine or cow-based. But the hormones are all plant-based. The creams and the oral estrogen are vegan. But the hormones themselves are plant-derived.
Okay.
We used to say they were derived from yams, but there was some weird world yam shortage. And so they had to find some other root vegetable to make these out of. So some of them are yams, some come from other root vegetables. I don't think there's a difference, but we did have to change what we say because we want to be honest.
Yam shortage. Okay, Hannah would like to know, and Hannah, if we can answer this, then we're all going to be in business making lots of money. How long does it take for weight gain to slow? I'm very active and still have gained 20 pounds.
Yeah, I mean, I think it's hard to answer that question, that would be universally the right answer for every patient, right? So everybody has their own timeline, but typically, like if your weight gain is hormonally related, typically once we get your hormones balanced, when we start your HRT, that's one of the benefits that patients notice to kind of come on last. Like their hot flashes usually get better first, night sweats get better, they start sleeping better, their mood starts to get better, the brain fog clears, and I have patients writing to me, okay, when am I going to start losing weight? And often it's like, we need you to continue and kind of keep hanging in there for us, because usually it's not until that month 2 or 3 that you really start to notice the benefit of the weight loss that comes from the medications. But each patient is unique. Everyone is that, unique snowflake, and that our bodies are different, our metabolisms are different. And you really have to look at every aspect of your health and, your nutrition to see, what it is that's affecting weight gain.
Christy had a question about how long Winona's been here. I just reiterated in the chat. We already talked about it, but went ahead and added that answer. Lorraine is asking if the initial medications prescribed are on the low side of the maximum dose, and she's saying that she's used to taking meds at an initial dose and then moving up as you get used to them.
Yeah.
So that's so I designed the algorithm that sort of not only chooses the medication, but it suggests a dose for the doctors. The doctors are free to change that dose, but it kind of gives a suggested dose. And it's really aimed at almost what you need. So the majority of patients, it's enough, but I always try to aim on the low side rather than the high side. My philosophy is that I'd rather not quite give you enough and have to kind of bump it up a little bit than give you too much and cause side effects and make you even more miserable. So we sort of aim for the right dose, but a little bit on the low side. And then it's much more common at that 3-month check to say, hey, we probably need to increase this a little bit. It's pretty unusual that we say, yeah, maybe we overshot this, we need to decrease it. And it's designed that way because I think it's the way I would want to take a medicine. It's like, again, the idea is to be on the least amount of medicine you need to fix the problem. And so that's the way we dose it.
Okay. Cheryl would like to know if there are any side effects with our HRT.
Well, with any medication, your body can react in different ways. And so there's some common side effects that we see pretty routinely. So for instance, with estrogen replacement, typically patients talk about feeling bloating. Sometimes they'll get breast tenderness. With the DHEA, the most common thing we see is some acne development because it can change the way that your skin responds. Progesterone tends to make patients a little drowsy. It can also slow your GI transit, and so that can contribute to a little bit of the bloating and also some water retention too. So those are the most common things I see, and every once in a while I have other symptoms that come up for patients, but those are the ones that we see, I think, the most. I don't know if you'd like to add to that, Dr. Green.
Yeah, I mean, and generally it's frustrating actually because the side effects tend to come on early and the benefits tend to come on later. But the good news is the side effects then come on early and then go away early, and then the benefits start showing up. But it can be frustrating for people that, I've been on this medicine for 2 to 3 weeks and I actually feel worse than when I started. And it's like, well, your body's adjusting, and that's when the side effects tend to happen. And they usually go away on their own. And then you start feeling a lot better. But it's hard to get through that initial part where you're feeling worse. So I totally understand that. But usually if you hang in there, they get better.
Okay, Brooke would like to know if either of you can talk about progesterone with no uterus, ovaries, cervix, and tubes. Some doctors say no lady parts, no progesterone at all, while others are saying we still need progesterone even with no intact lady parts.
Well, we kind of touched on this a little bit earlier in the webinar, but generally the main point of having the progesterone added to your HRT is to protect you from overgrowth in the uterine lining. So estrogen has so many beneficial effects throughout the body, but the one real negative that it has is it can cause that uterine lining to overgrow or proliferate. And if we don't keep that in check, it can lead to what we call hyperplasia or even cancerous growth. So that's the main reason for adding the progesterone, is to counterbalance that effect of estrogen on the uterine lining. So for me, if you don't have a uterus, why take another medication that's going to have no other significant benefits to you? I mean, I still have patients that say, they really want the progesterone, they've been on it before, they feel like it may help somewhat with some of their menopausal symptoms, but just the data out there shows us that estrogen is much more effective in treating the symptoms of menopause than progesterone alone. But if you really, really want the progesterone, you've been on it before, I've been okay with prescribing it after discussions with patients, but you really don't need it. It's not a necessary aspect, of the hormone replacement if you don't have a uterus.
And it gets back to that. You want to be on the minimum medication you need to treat your symptoms. And so why add a second medicine where you have the risks of that medicine and the side effects of that medicine if you don't really need it? I know that there's a lot of stuff on the internet about progesterone. This has been going on before the internet. I probably shouldn't talk about this, but my wife her friend sent a book that kind of inflamed me when I was a brand new OBGYN, because she said that OB-GYNs don't know anything about this, so he needs to read this. And it was, all the benefits of progesterone without estrogen. And then the last chapter of the book was that their progesterone was the only one that really worked, so buy our progesterone. But this has been going on. Yeah, this is, I mean, technically not before the internet, but pretty much, we're talking like 99. So I mean, I guess we were starting to get on the internet back then, but before we had all those blogs and YouTubes and stuff like that, this has been going on for a long time. But it really, for most people, really the science supports that you don't need progesterone if you don't have a uterus.
Okay, we have a very good question from Lorraine. She's asking, should I update my meds when I get new ones? For instance, her primary care NP has prescribed metformin. She's pre-diabetic, but she's taking it as a precursor to Wegovy.
Yes. Anytime you're getting medical care of any kind and you're getting treatments and prescriptions, you always want to make sure that whatever the provider that's prescribing for you, you keep them updated on what you're taking, because it's important for us to take a look at your med list to see if anything's going to interact. So that same thing goes for Winona. Even though this is not a doctor's office that you're going to in person and filling out forms, like you're still doing that kind of interaction with us online through our platform. And what we need to be able to take care of you safely is we need your medical history updated whenever you have any changes, any new diagnoses, or if you start new medications or you stop medications, to let us know so that we can update your chart. Because really that allows us to take the best care of you and to keep you safe.
And I'd say the opposite goes as well. So make sure you let your nurse practitioner know that you've started hormone replacement therapy, so they can update your chart on that end as well. You get best health care when whoever's taking care of you knows as much as possible about you. So that is very helpful for everybody.
Great. Our next question is from I hope I say this right, Nathifa. She says, Dr. Green, she appreciates your responsiveness when she reaches out via the portal. She posed this directly to you, but she's going to include it here. In using the cream, her symptoms are odd. She feels the cramping in the uterus area when she applies 2 pumps. As such, you suggested lowering the dose. Something she didn't share is that she believes this has caused additional weight gain, already gained weight from experiencing menopause.
So yeah, your cramping it's a pretty unusual symptom, honestly. I haven't really come across that very much. But generally, the general rule of thumb is if something is causing side effects, try decreasing the dose, and often that will take care of it. The weight gain, weight gain early when you first start the medicine is actually not that uncommon, because a lot of women will get water retention in the first several weeks to some people even a month or two. And that water retention can be scary because it can jump the scale up pretty quickly. That tends to go away with time. It's not sort of real weight. It feels like real weight, your clothes fit different and your scale looks ugly. But it's really hydration, it's water. And that usually goes away with time. So for most people, that sort of self-corrects. But try the 1 pump, like we talked about, I think it was this morning, and see how that works for you. It might make the difference. And if a lower dose, takes away the side effects, hopefully we'll still cover your symptoms. And maybe we'll, sometimes there's a little bit of trying, a little trial and error here because everybody responds differently. So we sort of take our best educated guess on what's going to work for you. And most of the time we get it right. Like I said, sometimes if, we try to aim a little low than a little high, but every now and then people have unusual or unexpected side effects and we need to decrease the dose a bit. I think that really might help you, and please continue to communicate with me online and let me know how it's working for you.
Okay, Brandy is asking, she's been on the lowest dose of the patch and 200 milligrams progesterone pills daily for 2 months. She's happy because her hot flashes have completely gone away, yay, and sleep has improved significantly, but she's noticed her belly getting a little bigger and she feels like she has an extra layer of chub all over. Sorry, I'm not laughing at you, just with the situation. While it's totally worth it, would it be worth trying the cream to get less hormones? She's also had some spotting and gets menstrual cramps every once in a while.
So, the only thing that sticks out to me listening to you read that question, Angela, is that if she's saying that she's on the lowest dose of the patch and taking 200 milligrams of the progesterone, maybe we need to adjust the progesterone dose a little bit. I see Dr. Green shaking his head. It's always nice to get that validation.
I'm like, yeah, that's what I was thinking.
Yeah, because I'm thinking if you're on the lowest dose of the patch, maybe the progesterone needs to be dialed back a little bit. And so that's something to consider. really, if you're already taking the estrogen topically with the patch, I don't know if switching to the cream would change that, but maybe you would tolerate the progesterone better and have less of the side effects if you switch to the compounded cream with the estrogen and progesterone. I mean, it's worth a try. Sometimes trying these medications on is like trying on clothes. It's really like a trial and error, and you never really know how it's going to fit until you put it on. And until you give it a try. And so every patient's unique. So maybe you would do better with the cream. It's worth trying for a month or so to see if you feel better with it.
Okay.
Go Lorraine.
Multiple Lorraines. Woo! Okay, Natalie has a very good question. She says, how do you monitor hormone levels and how often is it checked? Her blood work up. My blood work up, hormone levels stated I was post-menopause. 1 year ago, she had a hysterectomy, still has ovaries, but the menopause symptoms are hitting the last 2 months. She's scared of estrogen, lost her mom to estrogen-driven breast cancer last year, and thought it was good to balance progesterone and estrogen, and now she's confused.
Yeah, so really we don't monitor hormone levels. And this is one of the main medical conditions where we don't, so if you're anemic, we monitor your iron levels, we supplement that. If you have a thyroid disorder, we're checking thyroid levels. But when it comes to menopause and perimenopause, really it's best to be treated with the treatments and with the medication based on your symptom profile. So checking the hormone levels isn't real accurate. The hormone levels can vary from time of day we check them, whether you had a meal before you had them done, whether it's the morning or the evening or from one day to the next. And so the hormone levels are really just not very helpful for us to determine like what dose you need or if you need a change. It's really based on how your symptoms respond. And as far as feeling scared of estrogen, of course, having your mom go through a breast cancer experience, that's scary for anybody. And especially if it's hormone, receptor positive breast cancer, of course, it makes you concerned. So this is a personal decision that you would have to make and something that you could talk to one of our doctors about, the risks and benefits. But it's something that if you have not personally had a history of breast cancer, it doesn't mean you can't because of your mom's history. You're still a good candidate for it. And the fact is that if we all live long enough, men are going to be prone to getting prostate cancer and women are going to be prone to getting breast cancer. It's just one of those things that it's a fact of life. The longer we have these organs, they have the tendency to turn into cancer. So taking HRT to help symptoms that are affecting your quality of life right now doesn't mean that they're going to give you breast cancer if you take them right now. It's everybody's risk is unique based on what we've been exposed to, what our family history is. You have to really think about the risks and benefits. Are your symptoms that you're experiencing bad enough that it's affecting your quality of life? Do you want to be happier? Do you want to feel better? And that you have to personally be willing to accept the risk for yourself. So, but something that we could talk to you about if you on board with us for Winona. So.
Let me just also add on, there were 2 very large studies that showed a slight increased risk of breast cancer for women that took HRT that still had a uterus and that took estrogen and progesterone. But those studies showed no increased risk of breast cancer for women that had had a hysterectomy and only took estrogen. And one of the studies actually showed a slight decreased risk of breast cancer, although most of us don't really believe that. But particularly for you, since you've had hysterectomy and you only need estrogen is actually very safe as far as breast cancer risk. So, and this is this common misconception out there. Everyone's afraid of estrogen. It's really the progesterone you ought to be afraid of. You don't really should be afraid of the progesterone either. But the estrogen is actually much safer from a breast cancer standpoint than the progesterone. If your mom wasn't BRCA tested or you haven't been BRCA tested, it might be something to consider. You might want to talk to your regular doctor about that. That would be another thing to look into.
Bethany would like to know, do you have to have all 3 prescriptions, estrogen, progesterone, and DHEA, or can you reduce it to only 1 or 2 of them based on your symptoms and the side effects you experience when taking all 3?
Well, so yeah, we can make your prescriptions unique to you as far as what you decide you want to take. But if you have a uterus, you have to take progesterone along with the estrogen. You can't kind of pick and choose. Every once in a while, I get a patient who still has a uterus and says, well, I really just don't like the way the progesterone makes me feel. I want to take that out. Nope, sorry, we need that to protect your uterus. And so, but I have had also patients that maybe don't want to take the DHEA, or I've had patients that only want to take the DHEA and are not ready quite yet for the estrogen and progesterone. So, it's a conversation that we can have with you after we review your medical questionnaire or your symptom profile and come up with a good plan that we both agree with.
Mindy is asking, how long does it take for HRT to work, roughly? She says she has weight gain, sleep disturbance, occasional hot flashes, moodiness, and basically second puberty.
That's a unique way of saying it. I don't think I've ever heard a patient call it second puberty.
It is, yeah.
Yeah. I mean, normally, the symptoms of the hot flashes you start to get improvement earliest on, and then you start to notice improvements in sleep. And as far as your mood stabilizing, that starts to come later. And then also the weight gain, like we mentioned earlier, the weight loss can happen a little bit further down the road. But most women notice some improvement within a couple of weeks of starting the medications, and they start to notice some improvement and positive changes.
Okay. Someone's asking about the advantages of cream over oral prescription.
So the main advantage is that by taking something transdermal or through the skin, you're avoiding your GI tract. So if you take an oral pill, you have to take that pill. It has to be broken down by your stomach and your intestine before it gets processed and sent to the bloodstream to get to the intended tissues. Whereas if you're putting it on your skin, it's getting right into the bloodstream through direct absorption. And so you're bypassing those GI side effects. So that's the main thing. You won't get the gastrointestinal side effects of the medication.
This is a good question. This next one, I'm just making a note. Melissa is asking, how do you make prescriptions or creams specific to each woman if it's unclear what hormone levels are, since labs aren't useful?
So your symptoms, there's a lot of things about you that are unique. So we take a lot of things into account when we decide what we think is going to be the best combination of medication and dose of medication. There's only so many combinations and doses, so a lot of people are on the same combination and dose. So if you go on the Facebook Women's group, you're going to find that a lot of people may be on the same thing as you. Doesn't mean it's not personalized, but there's only so many ways to do it. But we really do look at all the information that you give us and use that to try to really narrow it down and nail down the dose and the recommendation of which medicines and what level, what dose to give you. And again, it's based on your symptoms. It's also based on your history and certain other characteristics. So it's a little complex, but it is personalized that way.
Okay, Lanisha would like to know, she says, you keep mentioning compounded cream. Do the benefits mentioned for the cream also apply to the pills that you provide?
Yes, they do. By far, I think the majority of our patients tend to use the compounded cream. I think that's probably the most heavily utilized form of medication, but the benefits that you're going to get from the HRT extend to the patch and to the pills as well. Really, it's about giving you that estrogen and you getting the benefits of that.
Yeah, they all work really well. It mostly comes down to personal preference, I think. There's very few patients where there's really a significant medical push to go one way or the other. It really comes down to what seems to work best with your lifestyle. And if you're on estrogen and progesterone, the creams are the cheapest, so that's kind of a bonus too.
Marcia says she's 55 and had her period up to recently. Her question is, how long can she be on HRT, as she hears that HRT is not for those over a certain age?
Well, we kind of touched upon this a little bit earlier in that we talked about the importance of starting HRT before the age of 60. But there's really no, certain cutoff time that, that's a hard stop, that you have to completely stop the medication. So, you can be on the medication for 3 years, 4 years, 5 years if you want, or I've had some patients that really want to stay on it for 10 years. So this is a, conversation that you'll have with your physician, and we'll talk about the risks and benefits of continuing versus stopping.
Okay. Jacqueline says the transdermal cream has absolutely halted daytime hot flashes. Good. Still has occasional night sweats, easily emotional, ridiculous muscle aches. Ideas for muscle aches? She's not at all sedentary.
Are you getting
So-
dehydrated?
Yeah.
Muscle aches is an unusual side effect. It's not something that I hear much. So I'm wondering if maybe you're getting dehydrated. I don't know. Do you have any thoughts?
I have not heard that from patients either, having muscle aches. So, I mean, if you're saying you're not at all sedentary, I'm guessing that you're pretty physically active. And yeah, if you don't get enough hydration and you're not hydrating the muscles, you'll get a buildup of like that lactic acid, especially if you're working out a lot. And so sometimes that could be causing it. The other thing to think about too, I mean, I don't know, somebody might mention muscle aches, but maybe they are really mentioning, like maybe they mean like Charlie horses. Sometimes that can be a sign of like a vitamin deficiency, something else to look into, but not likely related to the medications. I've not had that, complaint from patients really.
Yeah, I think about your other medications. Statins are pretty famous for doing muscle aches. I don't know if you're on a statin like a Lipitor or something like that. So thinking about your other medications as well. We don't know what you're on, but that's something to think about at least, because there are medicines that do this, but HRT not typically.
Lorraine is asking if we haven't discussed DHEA yet. She was reading about it, but stopped because it was a bit scary. So,
yeah. I mean, Dr. Green talked about that earlier, and that, some of the negative information that's out there is really talking about DHEA when it comes to the very high doses that people are using, as a performance enhancing drug when they're, lifting and powerlifting, things like that. We're using DHEA doses that are safe and pretty low doses. So generally, a lot of the data that you'll see out there, and I think one of the famous pages that a lot of patients go to when they Google DHEA, it's like the Mayo Clinic page, I think, Dr. Green, right? Isn't that the one that it's like this one page and they're like, please stay away from DHEA, but really they don't specify, they don't talk about dosage, and they don't really clarify that they're really talking about those high dosages of DHEA that people are using.
Yeah, the Mayo Clinic is really anti-DHA. It's kind of a scary.
Yeah.
Yeah, but they're really talking about a whole different thing than what we're using. And DHA can be, for some people, a really effective medication, because it does increase the testosterone levels to normal female levels. So it's not going to turn you into Arnold Schwarzenegger, but it will help with libido, weight loss, energy. It can be very effective for those things. So for some people, it can be very helpful. And it really is, in the 25 to 50 milligram dose range, extremely safe.
Sorry, I scrolled down and now I'm having to find my spot again. So it looks like I answered some questions in the feed. Is there a concern? Oh, sorry, this is a DHEA question. Well, now we have a lot of questions about the DHEA. What is scary about DHEA, as Lorraine mentioned? And Lisa also.
I mean, again, look, there's guys in my gym that are using 200-300 milligrams a day of DHEA, and then they also use other drugs to block. They're never just on that, but at those dosages, they're really pushing their testosterone levels high. And if you push your testosterone levels that high, it can cause a lot of side effects. It can cause male pattern baldness. It can cause hair growth. It can cause voice deepening. It can cause clitoromegaly. Some of these are irreversible changes. It can also cause interactions with other medications, like we talked about, like the SSRIs, like some of the antidepressants. That's not going to happen at the 25 to 50 milligram dose. And that's where all this confusion comes from, is that these warnings are because people are using these medications in a really completely different way than sort of the safe way that we're using them. And so when you read online, they don't say, well, yeah, we're talking about these giant doses. They're just saying DHA causes these problems. It's like, yeah, if you take enough of it, it does. But at the 25 to 50 milligram dose, it's not going to do those things.
Okay, Lisa's second question was, does she have to wait to shower till after applying the estrogen cream?
Well, so I think, was she asking how long she has to wait to shower? Because you can put it on clean skin like after you shower, or if you're applying the cream and then you go to work out or something and you're worried about showering too soon, generally the medication's absorbed within the 30 minutes. So if as long as you wait that period of time, then you're not going to be washing it off necessarily, if that's the concern.
I think Lisa is sort of piggybacking on this DHEA conversation, asking if we suggest that our patients use DHEA. Obviously, that's sort of case-by-case basis. She wants to know if it's considered unnecessary if you're on HRT.
So DHEA provides the testosterone for us, is really what we're using it for. It breaks down into estrogen and testosterone. And that's the other thing on the Mayo site, is they say, oh, it's going to bump your estrogen levels too high. People say, yeah, if you're taking giant doses of it, it will. But number one, we take that into account when we prescribe the estrogen, but it really doesn't change it that much. So it can be really helpful for testosterone. Even though we think of testosterone as the male hormone, the ovaries do make a small amount of testosterone that can be very important for women's health and particularly how they feel. So things like libido, energy, weight gain can all be affected and all be helped by adding DHEA. So it can be a very effective thing to add to the estrogen and or progesterone, depending on the symptoms.
Okay, Tracy says, is there any concern with the Swedish study regarding HRT and dementia? The study showed a link.
So it didn't show a link. Well, it did show it. Well, let me put it another way. The study was interesting. It said that people that have ever used HRT were at higher risk of dementia. But the interesting thing about the study is that if you were on it for one day, you supposedly had a higher risk of dementia. So if you actually read the end of the study where the authors discuss what they think the significance is, they said this doesn't really show causation. It doesn't show that HRT is causing this. And based on all the other data out there, they don't think that it's causative. And I think that's been the what the consensus opinion is right now. There's some mixed data, but the overwhelming data shows that HRT, is protective against dementia and Alzheimer's. This was this interesting study, and there were some problems with the way the study was done. But it really, the fact that you had the same supposed increased risk if you had 1 day of HRT or if you had 10 years of HRT makes you really wonder if this was causative or it was really a marker for something else, which is what the authors really thought, that this probably wasn't causative. There was a study that came out the week before that really actually showed the opposite. That study said that women that started menopause at an early age were at higher risk for Alzheimer's than women that started menopause at a later age, and that one of the issues was that women that start menopause at an early age are often not given HRT because people don't recognize it, because they think, a 39-year-old can't be going through menopause. And so they were much less likely to get HRT, and they thought that was the reason, or at least one of the reasons, that they were having an increased risk of Alzheimer's and dementia. And so in that study, the conclusion was that starting HRT earlier was important to protect against dementia and Alzheimer's. So, you don't want to sort of hang your hat on one study, especially when it goes the opposite of like most of the other studies out there. It's kind of like the joke when you're going on the freeway and everybody's driving the wrong way, maybe you're the problem. And so when you have a study that says the opposite of everything else out there, you got to think maybe there's a problem with the study. And so I think the consensus opinion out there about this study is that it's an interesting thing, but it's probably not causative. It's probably not that HRT caused the Alzheimer's or the dementia.
Tracy wants to know what's considered low versus a high dose.
I don't know if we really can get into that much detail, like on a webinar call here. But I mean, generally, depending on what form of medication you're on, whether it be the cream or the patch or the pill, we generally start you at a low dose and titrate up as we need to. I don't know if we want to go through all the possible strengths that we could prescribe, as far as low versus high. That's probably a little bit too much detail for this kind of call.
Okay. Okay, Melissa says she's postmenopausal. How often should you have an ultrasound to check thickness of uterine lining? She just transitioned from estrogen patch to progesterone pill after 6 months and has been doing the cream in the same dose, 5/200, for 1 week. She noticed an increase in hot flashes from switching from the patch to the cream. Is there a reason for that?
So there is no recommendation to randomly have ultrasounds to check for the thickness of the uterine lining. It's not like a screening mammogram like we recommend to screen for breast cancer. So the one good thing about uterine cancer, of all the GYN cancers that you can get, is that it bleeds, and that's how we diagnose, and that's how we start to, suspect it. So generally, if you were to have postmenopausal bleeding that's abnormal, then we might get an ultrasound to check the thickness of that uterine lining, and or just discuss talking about doing a biopsy to rule out abnormal cells. But it's not something that we routinely recommend for screening for patients. And then the question was, she switched from the patch to the cream and started to have a change in symptoms, an increase, was it, Angela?
Increase in hot flashes from switching from the patch to the cream.
Yeah, so I mean, it depends on if we, gave you the same dose or similar dose, but also the way that your body is responding to the hormone. The patch is, stuck on your skin, and it's slowly released over the day, while you have that patch on. So some people think that there's more of a steady state of the hormone in your system. Whereas when we apply the cream, like we're delivering that medication, it's getting absorbed by your skin. So that might be the difference, in that you might have more medication right after the application and a higher blood concentration, and it might change until you have your next application of cream the next day. And this is something that, when you start to notice a change in symptoms, we might need to tweak the dose a little bit just to see if we can get you feeling better. But talk to your doctor about it. Since the way I'm assuming that she's already on her Winona meds, even though
she's only been on it. Yeah, it's just only been on a week. So I think this is probably the cream hasn't kicked in yet. The cream takes my experience is that the cream tends to take the longest to really get blood levels compared to the patch or the pill. And so if you've only been on it for a week, my guess is the estrogen from the patch is wearing off, and the estrogen from the cream hasn't really kicked in yet, and you're getting caught in the betweener. So I'd give it a couple, 2-3 more weeks, and I think you're going to find the cream will catch up and should take care of your symptoms. So it's only been a week. You're probably just getting caught in between, and I think it's going to get better.
Okay. Brooke is asking, I know she asked this question before, but I think she's wanting clarification on this. So she's asking, why do some doctors say then that we still need progesterone when taking estrogen with no intact lady parts? That she's confused. Why would other people say that?
I don't know. I can't answer to why they would say that. I can just tell you that it's not necessary. That we talked about the reason why you need progesterone to counterbalance the estrogen. I don't know why there's some people out there that truly believe that progesterone is in itself, something that they would recommend that you take even if you don't have a uterus. I can't get inside their head and tell you why they're recommending that, unfortunately. I can only tell you what Dr. Green and I recommend to our patients, is that it's not necessary if you no longer have a uterus.
There's also this issue of education in that when the Women's Health Initiative study came out in 2002, it caused this panic and everyone stopped using HRT. And since then, even the authors of the study have said, no, you guys got it all wrong. HRT is safe. And there's a lot of data that's come out to say that, but it really scared everybody. And so there was a good chunk of time there where people in residency, the doctors in training, weren't getting trained on HRT. And so they were sort of having to pick things up as best they could. And so there's a lot of well-meaning people out there, well-meaning doctors that are doing the best they can, but they really didn't get any formal training in this, and they're trying to pick it up. And so not to say that your doctor is a bad doctor, or they're, or they mean poorly for you, they're doing the best they can. And I don't know if that's the case with your doctor, but I do know that, look, I'm the one that hires the doctors for Winona, and a lot of the doctors say, gee, I'm not very good at HRT. It's like, well, I'm going to educate you, and we've got a lot of resources, and we do a lot of training for our doctors to bring them up to snuff, because honestly, it's just not something that we get a lot of training and information on in residency, especially in the last 10 to 15 years. So there is a lot of misconceptions out there, and not everybody is up on the latest literature, quite honestly.
Okay, we have a few more questions. Marcia would like to know, does it matter which HRT you decide to take, the cream in the morning, DHE pill in the evening, or at the same time?
Really, the best time to take it is when you're going to remember to take it, and you're going to take it the same every day. I have my preferences as far as like what I personally do, and what I found to work a little bit better is I like to tell patients to use the DHEA in the morning. But if it works better for you to take it in the evening and that's how you're going to remember it, do that. A lot of our patients that are using the compounded cream like to use it at night. It tends to help with their sleep, tends to help with the night sweats more at night. And also just living our lives and going about our day, it's easier to apply a cream and then go to sleep, and not worry about, is the cream going to rub off on your clothes, or if you go to the gym or something like that. But like I mentioned earlier, it's just whenever you can remember to take the medications and use them regularly.
Tina is asking, why would an OBGYN say compounded meds are not safe? And I'm assuming this is related to some of the narrative around like the regulation of compounded creams. So Dr. Green, Dr. Cat, have at it.
Yeah.
We beat this one a little to death tonight, but the issue is that there's real variation in who's doing the compounding. Compounding is a bit of an art, and you need skilled pharmacists to do this. And we're very fortunate at Winona. We have our own pharmacy. We have some just amazing pharmacists. These are some of the smartest folks I know, and they're really careful to do it well and do it right. And so we know that we're providing a really safe and effective compounded cream. And quite honestly, that's not true with everywhere. And there are some things that are labeled stuff that really don't have that in them, as we talked about earlier. So I think that's probably where this is coming from.
Mm-hmm.
All right. Okay. I think we only have a few more questions. April's telling us that she has her waistline back after 2 months, and she wants to know if we've thought of adding probiotics to our list of things we are going to offer patients in the future.
So I had somebody tell me this in training, and it stuck with me. And I said, do it really well. Don't mess around with stuff you don't do, because you end up hurting patients. And so, that's always been my philosophy. I'll have patients in the office that want me to take care of their blood pressure, their hypertension. It's like, well, I could look it up and probably get away with it, but you don't want the guy who's writing your medicine to have to be looking it up to figure out how to do it right. You want somebody that does this every day. And so at Winona, we really do one thing, and we try and do it extremely well. And that's hormone replacement therapy. So at this time, we're sort of not doing other things, even if they're sort of somewhat related. And that doesn't mean that won't happen sometime in the future. But at least for right now, we're really trying to concentrate on what we do. And we try and, we think we are, and we try to be the best company that does this. And I think all of us individually try to be the absolute best doctor that does this, because that's what we would want for our health. And so by really narrowing our focus to one thing, I think we're able to do it really, really well.
Okay. A question about, do the creams need to be refrigerated? If so, how can they be stored when traveling?
They don't need to be refrigerated, so no worries there.
Okay. Next, Tiffany says, is DHEA the medication that helps with low libido, or is that something that will be helped with estrogen or progesterone?
Yeah, typically DHEA does help with low libido, just because that when it's broken down in your body to the estrogen and testosterone, it's the testosterone that really can feed the libido. But also supplementing with estrogen, if you've had vaginal dryness, helps to return health to the tissue. And so sometimes when your body's functioning better, your vaginal lubrication is improved, then that can also help your libido too, just because your body is like more readily able to engage in intercourse or sex. So the DHEA will help with the drive though. So I think in combination, these medications work together to improve that aspect of your life as well.
Okay. I think we just have like 3 more after this. This question is asking, they only sleep 5 hours with the cream, 50-50 estrogen, progesterone with the Biest Winona product, but it makes them sleepy in the morning. Should they increase the dose to sleep more than 6 hours in the night?
It's an interesting question. I would wonder if you're sleepy in the morning, if you should maybe try using the cream a little earlier in the evening. Were you going to say the same thing?
Exactly. That's me. Great minds.
Great minds think alike. Yes. Because maybe it's, you're only sleeping a certain amount of time just because you're not giving your body the chance to really get the full benefit of a full night's sleep. So maybe trying to make your administration time of the cream a little earlier in the evening, see if your sleep improves with that before we go changing the dose.
Okay. Lisa says, which prescription helps with loss of sex drive and arousal? I know we kind of just went over that, so we heard what that was. Morny is asking, she says her doctor said she had to use progesterone every day. Since doing that, she went crazy and now is on anxiety meds. Eek. She had a doctor in Rhode Island who had her on 5 days a month, and that's it. And he also had her on a testosterone cream. Why is it so confusing? If I use Winona, will I be able to transition off my anxiety meds?
I don't know if we can really answer that fully, because certainly having mood-related changes and having brain fog is, partially related to the changes of menopause, but there's other things that can contribute to anxiety as well. We all have different backgrounds and we all have different experiences and different stressors in our life. So, if your anxiety was related to the hormonal changes going through menopause, then likely the meds will help with that. And it is confusing when you have one doctor prescribe things one way and somebody else do a cocktail that's different. There's different ways to skin a cat. There's a lot of different ways that you can prescribe. Every patient's unique. And so what we try to do is to try to come up with the best thing. And for me, though, the best thing for most patients is something that's easiest to incorporate into their lifestyle. And sometimes calculating when you're on a medication and when you're not, taking it only certain days of the month and not, can be a little bit too confusing, and people tend to forget when to take the dose compared to doing something the same way every day, the same time. And so it is confusing. So maybe doing something more on a regular basis and a daily basis may work better for you. And maybe that would help with your anxiety too, because all those other things sound confusing to me just from the question.
Right. Okay. Let's see. Somebody else is asking, can you get your sex drive back from just the cream and DHEA?
Yes, a lot of people do.
Yes.
Not everybody. Libido is a very complicated thing. And so, if you're working 100 hours a week and you have a relationship problem and and that's what's driving your problem with libido, this isn't going to help that, obviously. And so libido is usually multifactorial, so it's hard to tell you that yes, 100% this is going to work, but for a lot of people it does work and it does help a lot. But I would also, whenever there's a libido issue, you want to take a big picture of it, and kind of try and get at it from as many angles as possible. Mm-hmm. When I have a couple in my office, I end up doing a little couple counseling. I tell the husband, it's like, look, you guys have been married long enough that foreplay is doing the dishes and putting the kids to bed, right? So sometimes you need some help, and if you're overwhelmed with stuff, that can definitely affect libido as well. So there's a lot that goes into it, but definitely hormone replacement therapy and the cream and the DHEA can be a really important part of that.
Okay, somebody's asking about going to the gym and sweating. Is that an issue? I guess that means if you're on HRT.
Or maybe when we were talking about the cream and the person who asked about showering, I think, as long as you've rubbed the cream in fully, and then you go to work out, really like that medication is absorbed within that 30-minute time frame. But if you generally rub it in until the skin is dry, at the site of your application, then you're good. The medication should be delivered adequately. You're not going to sweat the medication off, if that's the question.
Okay. All right. I think we have one. Sorry, I'm just looking to see two. We're just going to take these last three, and then I think we're going to be done. The question is, what is a safe level of DHEA to take without experiencing hair loss and other negative side effects? They started at 5 milligrams, didn't notice any effects, but are nervous about increasing the dose.
So we usually start patients at 25 milligrams. So 5 is a pretty low dose. The 25 is a low dose, but that's a safe place to start. And if we don't really see the benefits that we want and we want to increase it, we sometimes will increase that to 50, but then we typically don't go above that.
Okay, I'm just also adding in the chat. Someone was asking if they could have our emails. We can, if you want the answers, that if you have to log off, you can see the replay of this on our YouTube channel. So I was just adding that in the chat.
And once you become a Winona patient, you'll have access to us through messaging.
Mm-hmm.
Okay, let's see. Marnie is saying her doctor said progesterone causes, I guess she had an imbalance from being prescribed daily progesterone to only 5 days a month that she went cray. Her doctor said progesterone is what's causing that. You should just go through menopause.
Ooh, that's harsh. We don't do that with other things. Well, you just go through cancer. The treatment's brutal, so you should just go through cancer.
It's rough.
Yeah, like there should be a way to get you feeling better in a way that doesn't cause you side effects. Sometimes it takes a little creativity, usually not that much, but if you give us a chance, we should be able to find a dosage regimen that's not going to make you cray and is going to help with your symptoms. But just telling someone to suck it up and deal with it is kind of heartless, quite honestly.
Right. Yeah, that's pretty rough. Somebody is asking, I think this is our last question, if you have ever had anyone be on HRT that has not had relief from hot flashes.
Honestly, no. I mean, HRT is the best treatment out there for hot flashes. There's a lot of other medications out there that are non-hormonal in nature that people try to use for hot flashes, and I've seen more failures with those. But generally, with hot flashes and these other vasomotor symptoms, giving you estrogen typically works. Sometimes if we have patients that get relief but are still having some hot flashes, and so they want more relief or better relief, we might need to tweak the dosage. But I've never had a patient fail, like not get the relief from hot flashes with this treatment. It is really the best treatment out there for this.
Okay, just making sure I didn't miss anything else. I think that's everything. Oh, it looks like our official last is Brooke saying she's sorry to be a pain, but that her doctor said progesterone balances estrogen and there has to be a ratio, and that progesterone helps build, I'm assuming this helps build bones and helps thyroid function. Do you feel any of that is true? That progesterone helps with more than just protecting the uterus?
So the data doesn't show that that's the case. So I don't want to say it's true or not true, but I can say that the studies don't back that up. And it's really estrogen that's primarily responsible for increased bone health. And I forgot what and thyroid really shouldn't affect thyroid one way or the other, either estrogen or progesterone really. And so I would respectfully disagree based on the scientific studies that are out there. It's not what the science says.
Wow, everybody, thank you for all of your very informative, helpful, interesting questions. And for Dr. Kat and Dr. Green for staying here for 45 more minutes to answer all of your questions. This is just the kind of care you get at Winona, where your physicians are either taking webinar questions in their car or staying extra to answer your questions. So our doctors care about you. We really, really do. And
we're real people. Like you saw my daughter coming up telling me she needed something.
She's like, hey, Mom.
See my kid in the background in the microwave.
You've been on the call too long, Mom.
Your session is over, Mom.
I can't wait to make food.
Everybody, thank you for joining us, and thank you for your smart questions. And please, if you want to see the rest of this, if you missed any of it, you can look at YouTube. Our past webinars for prospective patients, current patients, they're all there in full. You can watch them anytime. There's a lot of helpful resources there. Also on our website, you can see a lot of journal articles that have been written by Dr. Green, and they're peer reviewed by lots of intelligent people who really want to help you understand menopause. So please check that out. And if you aren't following us on our social channels, you should do that too.
Marnie just put in one last question that we should probably answer, though. She said, how do we take the next step? So the next step is you go into bioidentical.com and you fill out the patient questionnaire and you start your onboarding and you start the process and start your chart. And when you go through that screening process, if we are located in the state that you live, your chart will be sent to one of us, like Dr. Green or I, and we could start the process there. So the next step is to go to the website and start filling out your information.
I just put a link in the chat, so feel free to copy and paste that somewhere where you can keep it, or click on it now and go start your questionnaire for us if you're interested. And we're happy. If you aren't already either, any of you who are here tonight, we have a women's group on Facebook called Winona Women. If you want to join, just request to join. It's not open to the public, but if you request to join, I'll be the one saying yes, you can. So just request and we'll let you in. You can have a whole community full of almost 8,000 women who will share in your journey and support you, we hope. So yeah, that's it, everybody. Thank you.
Thank you. Have a good night, everyone.
Yeah, I'll see you online.
All right.
Next month. Thanks, everybody.
All right. Bye-bye.
Bye.